So thank you. So Esther is going to focus her remarks more on some of the methodological issues that have come up. So if I can ask people to settle down so that she can begin, that would be great. Esther, over to you.
Thank you very much for the introduction, and good afternoon, everybody. It's my great pleasure to join you virtually for this session. I was able to listen to some of the presentations through the webcast, and I hope that what I'm going to be talking about is very complementary to the presentations of the day. So I would like to start you off on this conceptual framework. This is a framework that we have developed for our own thinking to help us understand the relationship between interprofessional education or interprofessional interventions and outcomes at various levels. And although it's a very simplistic approach to a very complex issue, I think it really helps us understand to really think about the different levels of outcomes that we could potentially tackle in terms of measuring impact for IPE and IPC. So I'm just going to lead you through the diagram here first. On the left-hand side, you see the interprofessional interventions, and I have used this based on the framework that has been developed by my colleague Scott Reeves, which has described interprofessional interventions as any education, practice, and organizational interventions that have been designed to improve collaboration and the quality of patient care. So they typically occur in an organizational context with an underpinning of person-centered care. At a first level, interprofessional interventions are thought to improve attitude, skills, and knowledge of other providers, of roles, of interprofessional behaviors, but really it's about the attitudes and it's about the knowledge. I think one important piece is the translation of the new knowledge and skills into interprofessional collaboration and interprofessional care, and that's indicated with the orange box here. For us, this is a very critical point. Maybe I have to preface that I work in a professional organization, a healthcare delivery organization as a researcher. And so my presentation probably reflects that to some extent, that I bring more the professional practice flavor into outcomes measures and what's important from a healthcare delivery perspective. Now, once you have changed behaviors, we like to think that we can influence two different pathways of outcomes. Towards the bottom, you see quality of patient care. So the idea is if you have interprofessional collaboration, if people work together, have better communication, you improve the quality of patient care, which ultimately leads us to better patient outcomes. On the upper half of the diagram, you see quality of workplace. There is some evidence that if people work together, the work environment actually gets better, they like it better, they feel they're more supported, and that ultimately should lead us to health workforce outcomes. And jointly, the health workforce outcomes and the patient outcomes should lead to better systems outcomes. So again, I apologize for this fairly simplistic approach, but I would like to do now is just run you through the different buckets of outcomes and discuss in a bit more detail what we can measure, how we can measure, and what the potential challenges are. So this is basically the same picture again in a little bit more linear way, and so I will continue to talk about the different levels of outcome. So let me start with interprofessional collaboration, interprofessional care. As I mentioned, the first level of outcome would be different attitudes, knowledge, and skills. So really enhancement of interprofessional competencies at that level. We talk about better role clarity between providers so they understand what the different roles are, where their competencies lie. A big focus is typically on communication. One critical piece is also the interprofessional leadership, that different students and practitioners understand when it's appropriate for them to take on leadership roles. So these are some of the very typical outcomes that are being measured. We recently conducted a bit of a tools inventory looking at the literature to see what kind of tools do we have to measure attitude, knowledge, and skills as an outcome of interprofessional intervention. We found over 140 tools, and as you can see, the big majority really focuses on attitude, knowledge, and skills. There are only a few that focus on behaviors. So that's kind of the preferred mode for measuring this particular outcome, self-reported survey tools. And I think the usual sort of limitations associated with self-reported tools apply to this particular outcome measures. In some cases, people have done observations, video analysis, or ethnographic observations, where they go into teams and just try to observe their interactions, see if they actually see any of those interprofessional competencies displayed. So this can be done as well, but it's less typical done. So the most common way to measure attitude, knowledge, skills outcomes is really through self-reported tools. Now, the second piece is the interprofessional collaboration or interprofessional care outcome. From a practice perspective, this is a very, very critical piece. I think it's fundamental that we can be quite certain that more positive attitude, knowledge, skills really translates into different professional behaviors, different practice behaviors. There are a couple speakers today that have alluded to that, Tina as well, in terms of the interprofessional collaboration. So the question is, how do we know that we have collaborative care processes? There are a number of typical processes, for example, interprofessional rounds that we could look at. We have other pieces like an integrated plan of care that we could take as an indication that interprofessional care happens or that collaborative practice happens. We have observed many interprofessional rounds. They happen on almost all inpatient units in our system. However, the quality of the rounds is very, very variable. So often not everybody that should be attending actually attends the interprofessional rounds. They're not efficiently run. They're not effective in a sense that there is no real accountability for decisions made during the round. There is quite often not a follow-up. So while we have an interprofessional care process, the interprofessional rounds, the quality is not such that we would truly say it meets our requirements in terms of high quality care processes. So I think one of the challenges is how do we actually define collaborative care, interprofessional care, what makes good quality care, and then how do we actually measure that? Another outcome at that level is for us working to full scope of practice. So we do quite a bit of research around the different scope of practice of healthcare providers, and we see substantial scope overlap between different providers. The idea is if we have good communication, if we have good role understanding, it would enable people to better understand how their skills are complementary and where they're the best person to assume a certain role versus another person. So we would actually see people working more fully to their scope of practice. Again, this is something that's really quite difficult to measure. So in terms of measurement, we focus on questionnaires. Quite often we do qualitative interviews, just trying to hear from the practitioners, how do you think you're working together, how it's functioning, do you feel it's interprofessional, do you really use your full knowledge and skills, or where do you see opportunities for expanding? We also have done observations. We have used checklists. So for example, for interprofessional care processes, we have designed some checklists that highlight some key elements of the processes that need to be in place. We observe for those checkpoints and see if they're done. So we have found a number of examples in the literature where that actually has been used as well. A bit more sophisticated approach in terms of looking at providers' roles and what is it they're actually doing is time function analysis. So it involves really observing people during a full day, coding the different activities in different segments and trying to figure out how they spend their time, what kind of activities, and what kind of roles. And this is consistent with a collaborative care approach. The second level of outcome I would like to talk about is quality of patient care and quality of workplace. So these are perhaps what you would consider a little bit softer outcomes. The idea is that if we have good collaboration, if we have good communication, we would see improvement in quality of patient care. On the patient side, I think we have fairly good measurements that would indicate high quality of patient care. Patient experience is one of the indicators that is quite commonly considered. It's measured through various surveys. They're really well-known, validated tools such as the HCAHPS, the PICR survey that really try to capture the patient experience. We can access administrative data and look at adverse events. So that would be anything from pressure ulcers to falls, any of those incidents. Being in a large organization, we have fantastic administrative data that capture a lot of these adverse events, capture a lot of these quality of patient care outcomes. So I think the issue is not so much the measurement piece. Sometimes the issue is you can't measure at the unit level, so it gets rolled up more to a higher entity, either the hospital site or a zone level. But in essence, I think we would have the means to actually measure those particular outcomes. Similarly, for readmission and length of stay, which we also consider a quality of patient care indicator. So the expectation would be if we do a good job in the hospital, we could potentially reduce the length of stay, although that's sometimes disputed. But we should be able to avoid unnecessary readmissions for the same condition. The last one on the list here is the care coordination. I think that's a little bit more tricky. It's not well defined what that actually means, care coordination. It's a little bit challenging to capture that with any kind of data. Quite often we resort to interview data. We have done a number of studies where we have followed the patient journey through the system and just looked at care coordination. And where the coordination falls apart is typically at transition points between the different health sectors. On the right-hand side of the slide, we have the quality of workplace. So I think there is a fair body of literature that documents if healthcare providers are working collaboratively, it actually enhances the quality of the workplace. And that has been described in many different ways. It's all a little bit soft and fuzzy, which kind of poses some challenges in terms of the measurement. A lot of this data is qualitative in nature or through surveys. And so people have spoken to the leadership support that they feel in a collaborative work environment. There is time for common reflection, which is really valued by the healthcare providers. They also refer to an interprofessional learning culture. So there's a sense that interprofessional learning is valued, that people are given the time to actually learn and improve. A number of people have spoken to the workload. They feel if they're working in collaborative teams, the workload gets more manageable because they share the work, they have a better understanding of actually what needs to be done and how to assign the work in a more meaningful way. The other piece that's interesting for quality of workplace is from the student side. So there is some evidence that when students come and do their clinical placements, a collaborative work environment is actually attractive to them. So given a choice, they choose collaborative practice environments to do their clinical placements. And sometimes it also prompts them to come back to the same practice environment to actually work there at a later stage. As I mentioned, hard to capture this kind of data, mainly qualitative or questionnaire. Now, the third level of outcomes, I refer to the patient outcomes and the health workforce outcomes. So for the patient outcomes, we have many opportunities to actually measure fairly solid outcomes. So there are health-related quality of life questionnaires that can be used. There are a lot of different ways to measure health functioning through functional scales. We can measure health outcomes. There are self-reported health outcomes scales as well, those PROMs, patient-reported outcome measures that are quite popular. So I think for this particular set of outcomes, the measurement is not so much the issue. The key issue, I think, is the attribution. I believe it was one of the speakers this morning that mentioned that only about 4% of the changes in patient outcomes can be attributed to changes in professional practice or team care. And so I think the challenge will be to make a really tight connection between any changes in patient outcomes that we see and the intervention that we actually have conducted. On the health workforce outcome side, we have some outcomes related to recruitment, retention, sick time, absenteeism. And I think, again, we have, for the most part, really good data, at least in our organization, and I would think for the most part in Canada. There are multiple databases, financial and labor databases that capture this kind of information that we can actually use to measure those outcomes. Student career choice might be a little bit trickier to measure. I don't think organizations keep a really good track record or do a systematic exploration of what has prompted a student to actually start work in a certain environment, in a certain organization. Can that be linked back to a clinical placement experience they had? Can it be linked back to the quality of the workplace? So that might be something we could consider in the future. Optimal workforce utilization, again, that's something that we have spent a great deal of time on it. In terms of defining it, which is quite tricky, so utilization really refers to how are providers organized and deployed in an organization to deliver patient-centered care. And it's really hard to define what that actually means to optimize that. But I think we would be looking for pieces like no duplications of activities or care processes done. We hear a lot from providers, for example, around patient assessments, that they're being redone a couple times because providers don't really talk to each other. The information does not get linked together in a common system, and so there could be an opportunity to look at some of those areas. We could look at productivity in terms of how providers spend their time. I think that links back to scope of practice and the different activities and roles that providers do, and if that potentially creates some efficiency in the system. As mentioned before, I think for some of these outcomes, we have good administrative data, optimal workforce utilization and productivity. I think it looks not so good. It's challenging to, first of all, define it, and then I think it's also challenging to really capture the essence of the outcome in a meaningful way. The last level I would like to speak about is the systems outcomes, and I have selected here to highlight return on investment on interprofessional education and interprofessional collaboration. I think that's a highly neglected area so far. So there is a framework, some of you might be familiar with it, Eddie Nason from the Institute on Governance in Canada has developed a conceptual return on investment framework on interprofessional education and interprofessional collaboration. And so this is a snapshot of the logic model from his report that's on the website of the Institute. And I think it has some interesting components that highlights a number of challenges. On the left-hand side, you see the inputs. So what is actually going into the interprofessional intervention in terms of labor costs, human resources, materials, technology, infrastructure, and processes. A number of years ago, we did a knowledge synthesis and looking at interprofessional interventions and HHR outcomes. And there were only about 2 or 3 of the studies that we have found that actually tried to capture the cost associated with those interventions. And so I think at the end of the day, sort of documenting that there is a return on investment on interprofessional education and interprofessional practice will be really essential to make a case for interprofessional education. And so assessing costs, really capturing them, is a first very critical point to understanding the input into the logic model. On the benefit side, he lists a number of outputs and outcomes, and I think, overall, they probably capture what we just discussed here. Process outcomes are more the softer components that look at the quality of the workplace, increased knowledge and skills. The big challenge in terms of measuring return on investment here is how do we possibly attach a dollar value to those softer outcomes. I think everybody agrees that they're important because they really signal that something has changed as a result of an interprofessional intervention, but it's going to be really tricky to attach dollar value to anything like people have enhanced knowledge or they have better competencies, and so that's going to be a challenge. In terms of the outputs, he talks here mainly around access to care, quality of care. I think some of the same caveats apply here too. As discussed before, we do have some good measures around quality of care in terms of the adverse event. Some might be a little bit softer and again, difficult to attach dollar values. Secondary outputs, he includes here anything from policy changes, professional guidance, which again are not very tangible outcomes. And then the ultimate outcomes would be health improvements, well-being, and then sort of more the impact on the broader society. Well, this could be measured potentially. I think the issue is the attribution to the interprofessional intervention. So in summary, my sense is from reading the literature, from our own research and from discussion with colleagues, my recommendation would be, first of all, really focus on measuring interprofessional collaboration and interprofessional care. I think it's a very important link in our chain of evidence to be able to demonstrate that positive attitude, knowledge, skills that we were able to enhance through interprofessional education, that this actually translates in meaningful, observable professional behavior, professional practice that reflects collaboration and that reflects interprofessional care. While there are some tools out there to measure that, I think there's a need to find more reliable tools, more systematic approaches, better definitions of what actually constitutes interprofessional care, high quality interprofessional care, and how do we want to measure that. I think we can be somewhat confident that once we have interprofessional care and that this will lead to higher quality of patient care and then to patient outcomes. The second point, I think, is quite weakly developed is health workforce outcomes. In general, I do feel that this is an under-researched and under-discussed area in the context of interprofessional education and interprofessional practice. There are not too many studies that actually look at health workforce outcomes. I would like to argue, though, that given that probably about 70% of the cost of running a health services delivery organization are related to health human resources, it's highly relevant what kind of outcomes we get through interprofessional interventions. So if we have a chance through interprofessional interventions to actually enhance the quality of workplace, and if this really truly translates into better recruitment, retention, more productivity, more efficiency in the system, I think that's an absolute win. So my recommendation would be to focus on that area to really try and understand, can we link health workforce outcomes, positive health workforce outcomes, to interprofessional interventions and collaborative practice. And then the last one, which I feel is under-researched as well, is the whole return on investment. I think the reality is, if we want to make a good business case for interprofessional education and interprofessional practice, we need to be able to demonstrate that it's a win-win situation for the healthcare system as well as for the patient. If we only demonstrate positive patient outcomes, but it comes at the exorbitant price, it's probably not going to be sustainable, and it probably will not get a lot of traction. The challenge right now is that not a lot of work has been done on return on investment. There's some cost effectiveness analysis, but that's not quite the same. I think the return on investment framework that Eddie Nason and colleagues have developed is a good starting point to actually think about the different levels of outcomes and how can we tackle the softer outcomes that it's a little bit more tricky to attach dollar values to it. The framework right now is at the fairly conceptual level. I don't think there are many people that actually have tried to apply it in practice. And so there is an area that would deserve further attention in terms of taking the framework and seeing, is it actually feasible to apply it in a practice context. So in summary, I would like to propose the following recommendations for measurement for future focus. Valid and reliable tools to measure collaborative behavior in IP care processes to really try and make that link between interprofessional education and practice change as a foundational element in terms of identifying future outcomes. If we can't be certain that the practice has changed, it will be very, very tricky to attribute any changes in outcomes down the road to anything that we have done on an educational practice level. And the second one, really focus on those health human resources outcomes, particularly in trying to define productivity and optimal workforce utilization. I think that's where the big wins are in terms of demonstrating positive outcomes at the health human resources level. I think these are really critical for being able to calculate return on investment. And then, as I mentioned before, really apply the return on investment framework more fully to case studies to understand what the benefits are. I'm going to leave it at that, and here just a list of some of the references that we have here.